All right, everyone, we're on week 15, which is hard to believe that we are almost done. But first, before we can finish, this is actually going to be a two-part lecture. The first is on obstructive urinary disorders, and then the second part is on male reproductive disorders. Okay, just a quick review on the urinary system functions. Regarding urine formation, about 1% of fluids filtered becomes urine in your body. As far as excretion goes, the urinary system is the main organ to do this. It eliminates wastes, drugs, and toxins. It regulates blood volume, pH regulations. Remember, we did speak about your acid-base imbalances, and the kidneys compensate for changes in the blood. This is where it is done. There is blood pressure maintenance. It secretes the enzyme renin when blood pressure decreases to help increase your blood pressure. And there is also erythrocyte concentration. Erythropoietin is produced in the kidneys and is released in response to decreased oxygen in the renal blood supply. This then secretes erythropoietin, the hormone, during hypoxia, which will increase red blood cell production in bone marrow. And then there is also vitamin D production, where the kidneys activate vitamin D for calcium absorption. So again, this is just a small bit of what the urinary system functions does, but as you can see, it can be quite complex. Okay, the first problem that we're going to talk about that you may come across with one of your clients is a urinary tract calculi, or also referred to as a kidney stone. This calculi or stone creates an obstruction, and depending on the location of the obstruction, you will hear various terms. Urolithiasis is when there's a kidney stone that's stuck in the ureter, and a nephrolithiasis is where a kidney stone is stuck somewhere in the kidney. Okay, urinary tract calculi, a little bit of the pathophysiology. This can be a metabolic defect, which is a deficiency in inhibitors of crystal formation and growth. Crystals from the materials are excreted in the urine that form calculi, and it's stimulated by meals high in minerals or decreased fluid intake. This cannot occur with adequate fluid intake. This will lead to backflow of the urine into the kidneys, which will cause dilation and stasis. And this can occur in about 12% of the population. Risk factors. Males, there's a 4-to-1 risk. So males are at a higher risk for this. If you have a family history of this, if you are dehydrated, remember you need to be bringing in adequate fluid intake to avoid this. If there's a diet high in animal proteins, calcium like dairy products, sodium products, sugars, corn syrup, oxalate, cola drinks, apple juice, grapefruit juice. There is a lot of different things in a diet, but if they are having excessive amount intakes of these, really more the animal protein, the calcium and dairy products, and products that are high in sodium, those can cause these urinary tract calculi. Also calcium supplements. There is a women's health initiative that has been increasing the intake of calcium for the bones, but then you are also at a higher risk to form these kidney stones. Conditions that can increase minerals, if you have gout, you have that uric acid crystal formation already, so this can be transferred to where it occurs in the kidneys. Hyperparathyroidism can increase calcium, and immobility can increase calcium. And then also urinary stasis. So if you are not relieving your kidneys and your bladder as much as you should, you could develop a calculi also. Symptoms of urinary tract calculi. An obstructed urine flow. Your client could be distended. Many times you will see hematuria in the urine, and it may not be visible to the eye, You may have to check it with a urine dipstick or send it to lab to see if there is traces of blood in the urine. Dysuria. The one that usually gets us is severe pain. Severe pain many times will be located in the flank region on one side or the other, and then it radiates around toward the genital area. And this can be quite obvious because when I say severe pain, it will be some of the worst pain that someone may have experienced in their life. And we actually kind of, when we see people come into ED with this, we like, oh, it looks like they're doing the kidney stone dance because they cannot stay still. But it is not a laughing matter because, again, this is some of the worst pain that somebody may experience. So treatment. Some stones will pass spontaneously, so that's actually the most ideal, but again, it can be quite painful while it is passing. They may do a cystoscopy where they go and they look up in the ureters and pull out the stones. There is many different types of lithotripsy. This is a probe that produces ultrasonic waves which break up the stone into sand-like particles. So treatment, hydration. Most of the time we don't have to give them IV fluids, but if they are very dehydrated, we'll do IV fluids, but again, encouraging PO intake. Meds that are related to the stone, we may have to alter if we think that's what's causing the formation of this. They may actually need a stent somewhere in their kidney to keep the area open where a stone has went. And they may put in a nephrostomy tube. So that's kind of a last case scenario. Most people, thankfully, do pass them spontaneously, but again, this is a very painful thing to experience. So nursing interventions, analgesics. These clients are going to need narcotics, and getting them comfortable is your priority when you first come across this. They may be given ditropan, which is an antispasmodic, to help because that will actually help the spasms, which will decrease the pain. You could put ice to the lower back, especially if they had lithotripsy. They may have swelling and bruising in their flank areas. So this putting ice to the lower back can decrease the swelling and bruising from the lithotripsy. Fluids, again, like I was saying, 3 liters a day is a priority to really flush out those kidneys. And they should be having a urine output of at least 2 liters a day, so your eyes and O's if they're in the hospital with this. You do want to teach the client that every time they urinate to strain it, and we do have strainers that we have the client put their urine through, and this way we can see if there are any stones that pass, or we can even see like the sand, the broken up part of the stones sometimes in this. And then they need to measure their urine. So what should they be restricting their diet with? Purine, calcium, oxalate, phosphate, sodium, and proteins. Again, everything is in moderation here. So if you see somebody has an excessive diet with one of these things that are included, the purine, calcium, oxalate, phosphate, sodium, or protein, some education may need to be done. So complications. We can get an infection from this. If you have urinary stasis and you are not urinating properly and clearing out the kidneys and the bladder, you are at a higher risk for infection. They may have hydronephrosis. So if you look at this picture that is up on your slide to the right, this is a dilation of the renal pelvis of one or both kidneys due to an obstruction. There is increasing pressure into kidneys that will result in kidney damage. And many times there are not any symptoms if it is a gradual thing until the fact where there is a full obstruction. At that point they may have kidney damage. They may have to place a nephrostomy tube. So if a nephrostomy tube is placed, you need to teach the client, and you as a nurse need to assess and report any bloody drainage at the site, any foul smelling discharge, any urine draining from the site, or if the drainage stops. Now, a nephrostomy tube, you're going to have the bag, so I don't want you to confuse this, but if you see urine draining from the actual site where the tube is coming out is what I'm talking about. There will be urine draining in the bag, okay? But again, if there's bloody drainage at the site, foul smelling discharge, urine draining from the site, or if the drainage stops, you do need to report this. And clear drainage is normal, okay? So that's not something to be so worried about. It's just the other things. So some prevention and patient education. Again, that hydration, that is their #1 defense as far as trying to avoid this occurring again. Dietary restrictions based on the stone type. So when we have them strain their urine, if we do get a stone, we would put that in like a urine specimen cup, and then we would get an order from our doctor, and then we would send it to the lab, and they would analyze it, and they could see what the stone is made from, and then that will give us a better idea what dietary restrictions may have to take in place. We may give medications like a thiazide diuretic, which will help increase calcium absorption, and then exercise. You know, we can't go wrong with exercise with just about anything. This will help pass the stone quicker and decrease bone calcium resorption. So this too will actually help. Okay, moving on with obstructions. There is bladder tumors and bladder cancer. Risk factors. Okay, the #1 risk factor is cigarette smoking. What happens is, it's kind of weird because you would think cigarette smoking is more affecting the lungs, but what happens is every time you are inhaling that cigarette, you're inhaling toxins into your body, and they do filter through and get down to your bladder. And because your bladder is kind of shaped kind of oval-like, the toxins will go to the bottom of the bladder and they kind of sit there. And then as they sit there, they do create a risk for cancer. So risk factors again, cigarette smoking is #1. Chemical toxins is another one because again, they do accumulate in the bladder. Chronic trauma, and not trauma like you're getting punched in the kidney, but if you have several UTIs, or you get kidney stones often, or you have to do self-catheterization, stuff like that can also be a risk factor. Pathophysiology, just know with bladder cancer, it's usually transitional cell carcinoma. And signs and symptoms is gross hematuria. It is painless most of the time, and they do eventually complain of dysuria. So further on, they do get that dysuria. Okay, now going over some of the treatments that you will see with bladder tumors and bladder cancer. And the degree of surgery is determined by the type of tumor. So, if there's a superficial tumor, that is not going to have as invasive or as much of a surgery as an invasive tumor. So again, it determines what type of treatment with how far along this tumor or cancer has gone. So the first one is a transurethral resection of the bladder tumor, or that is called a turbit, which you can see up there, it's TURBT. They may do intravesical chemotherapy, where the chemo is delivered directly into the bladder by a catheter. Or they may do a radical cystectomy with urinary diversion. So for men, they will remove the bladder, prostate, and seminal vesicles. And for women with a radical cystectomy with urinary diversion, they will remove the bladder, cervix, uterus, urethra, and ovaries. So this is quite the procedure that someone may have to go through. Complications that they may have is urinary retention, or they may have an inflammation of the bladder or cystitis. It's C-Y-S-T-I-T-S, cystitis. So prognosis is really good for a full recovery. 5-year survival rate can go anywhere from 55 to 91%, depending on how soon the cancer was identified and treated. Okay, so when you have a renal tumor that we're moving on to here, it could be benign, but unfortunately 85% of the time a renal tumor is malignant. This usually is an adenocarcinoma, and it metastasizes early. This is a malignant tumor formed from glandular structures in the epithelial tissues of the kidney, and the prognosis is poor. There is also paraneoplastic syndrome, which is a rare disorder that are triggered by an altered immune response to a neoplasm, which is new and abnormal growths of tissue in some parts of the body. This will cause a collection of symptoms that is caused by substances produced by the tumor. So you may see increased or decreased erythropoietin. You may see an increase in renin, which can cause hypertension. You may see an increase in your parathyroid hormone, which will cause an increase in calcium. And you may see an increased ESR, which is erythrocyte sedimentation rate. And this is the rate at which red blood cells sediment, and this detects inflammation related to possibly cancers and infections. So an elevated ESR does not give you an exact location, but if it is elevated, you are suspect that there is some inflammation going on. It could be due to a cancer. Symptoms: you rarely get any early symptoms, which is about 30% of the time. So that's unfortunate. Whenever you don't have early symptoms with any kind of cancerous tumor, you're at a greater risk for it to have spread. Other symptoms: you may get painless hematuria, but that is a late symptom. There may be a palpable mass in the kidney area. They may have weight loss and flank pain. And then look for paraneoplastic syndrome lab changes. So again, that was increased in renin, increased parathyroid hormone, which would show a higher calcium, and increased ESR rate. So there's many different things you could be looking at. Treatment: before it metastasizes, they will do possibly a radical nephrectomy. And whenever you hear radical, you know it's not good, because it's a radical procedure. So a radical nephrectomy removes the kidney, the adrenal gland, surrounding adipose capsule, and the regional lymph nodes. It's very vascular, with a possible removal of the ribs that are on the area too. So if they do have one healthy kidney, one kidney is enough. Dialysis is not necessary. But it can take days to weeks for the other kidney to take over. So there's some very close monitoring that is going to be done if something like a radical nephrectomy is done. They may do a radiofrequency ablation or chemotherapy to shrink the tumor growth. This here is a radical nephrectomy slide. And it's just kind of showing the areas that may be removed, which is your kidney, your adrenal gland, which is on top of your kidney, the ureter that's coming out of that kidney, and the surrounding fat. And again, remember, if you look to the right of that picture, you can see where the site of the incision is around the back, and right around that also are ribs. So again, they may remove some ribs also in this type of procedure. So post-op nursing interventions, you may see copious drainage at the surgical site. So be diligent on protecting the skin, keeping it intact, and watching that drainage. You also want to encourage your client to cough, deep breathe, because they are at an increased risk for atelectasis. You also want to have good pain control. Avoid turning your client onto the operative side, and you will need to provide emotional support due to uncertain prognosis. And when the client gets discharged, they must not participate in contact sports. So some complications that you may come across, an infection. Okay, an infection left untreated can go septic, so you want to monitor for signs and symptoms of shock, assess your heart rate, respiratory rate, and circulation. Signs and symptoms of shock, as a quick review, you will see an increase in the heart rate, you will see an increase in the respiratory rate, a decrease in the blood pressure, and a decrease in the urine output. And a little bit more about the decrease in the blood pressure. Hypotension is dangerous for the remaining kidney, which must receive adequate perfusion to function effectively. Your client may have metastasis even after this type of procedure, or an obstruction. Postoperatively, be on alert for hemorrhage. They could go into adrenal crisis. This is a stimulating of the adrenal gland. And what happens in adrenal crisis is it produces an insufficient amount of cortisol, which affects your stress response and your immune system response. So what that means is those catecholamines will go into a fight or flight response. And when you go into a fight or flight response, you're going to have an increase in your blood pressure and your increase in a heart rate. Okay, and these clients could go very hypertensive, and that obviously is not going to be good with that remaining kidney, so that is adrenal crisis. There is a poor prognosis. If caught early, you could, have a 44% survival rate, but it could be as low as 10%, if it's caught late. Okay, so now we're moving on to urinary diversions. And the purpose of this is to reroute urine flow due to a diseased or defective GU structure. So you may see someone with a urostomy, a suprapubic catheter, or a nephrostomy tube. Risk factors will include chronic infections and bladder trauma. Okay, some different types of urinary diversions includes an ileal conduit, which is the most common. This is where the ureters are implanted into part of the ileum. Urinary diversion and ureters are surgically attached to the ileum because the bladder has been removed and an abdominal stoma has been created. So if you look at this picture up here to the right, the system of urinary drainage, which is created by using the small intestine after removing the bladder. And then that's how they create this ileal conduit. Okay, so the ileal reservoir. The reservoir was made from part of the intestine, and the ureters are implanted to the reservoir with the stoma. There is a nipple that is created, and this is a continent type of procedure, which means that the client will have to be taught to self-catheterize him or herself to remove any urine. Okay, but again, it's not just going to come falling out of them. Bladder reconstruction, there may be a neobladder, which is a false type of bladder that is created, but there's no sensation of fullness. So that is something, they do have to be taught again as far as to make sure that that bladder does not get distended. Okay, so for nursing care with urinary diversions, preoperative care, evaluate the readiness to learn with your client, because this is another huge procedure that he or she will go through. They may be anxious. You want to include an enterostomal therapy nurse because he or she will be able to show them, different appliances that they have to help with them, the catheterization. They could give referrals for support groups. You know, they really are the expert with that. Then post-op care is going to be similar to fecal diversions. Okay, but with your stoma care, you want to instruct them no tight clothing around that stoma. The stoma will be red, you know, when it is first created. And the urine is very caustic to the intestinal lining. So there is mucus in the urine, which is secreted by the intestinal segment used to create the conduit. And this is a normal occurrence. So you want to encourage high fluid intake to help flush the mucus out of the conduit. The appliance, if they have appliance attached to it, you know, they do want to drain that when it's a third or half full. Or if they do have the stoma that they catheterize, you know, they want to do that every 4 to 6 hours. And that is going to be something that the client will have to figure out how often. You know, if somebody is drinking a lot of fluid, you are going to obviously have to do that more frequently. For diet, you want to avoid odor-producing foods such as onions, fish, eggs, and cheese. And again, body image, you know, this is a huge change in somebody's lifestyle because they will have a stoma now. There may be urine leakage with an ileoconduit. You know, if they don't go and do the catheterization as often as they should, they may have some urine leakage. All right, so that is it for the GU. Now we are going to move on to male reproductive disorders. Whenever you're discussing any kind of reproductive disorder, really male or female, you always want to provide confidentiality, okay, and emotional support. And again, use common terminology, you know, use layman's terms. This is not the time when you start throwing around medical terms to show them how smart you are because you just learned all of this stuff, because they're not going to understand possibly what you are trying to teach them and talk to them about. So, labs and diagnostic studies. The first one is a digital rectal exam, or DRE. This is recommended for men over 50 years old, and it should be done annually. And what is happening is we are palpating for enlargement and consistency. So we want to make sure everything feels uniform in the rectum. Prostate cancer will feel hard, enlarged and fixed, and irregular. So really, we are trying to make sure that the prostate is within normal limits and it has not become possibly cancerous. There's something called PSA, which is prostate-specific antigen. This is an indicator of prostatic cancer. So with the lab value, if they get a lab value under PSA of 0 to 4, there is none. Higher the value, the greater the mass. And this PSA level will fall when the mass is removed. And it will be elevated if the disease has reoccurred. And you do want to make sure that you draw the PSA before a digital rectal exam is done, because that could actually increase your PSA level. They may also do an alkaline phosphatase, which should be below 200. This alkaline phosphatase will be elevated with metastasis to the bone. And they may do a BUN, creatinine, and glomerular filtration rate, you know, for your kidney functions, because this can impact the disorder or obstruction on the kidneys, you know, so we want to make sure that they are functioning correctly. They may do a cystoscopy and biopsy. And if you look at that picture down there, you know, it doesn't look very appealing for a male to go through this, but they take a cystoscope and they look through the urethra, and then they will look up in the bladder to see, you know, how things look. And they may take a biopsy at the time. Or they may do a testicular ultrasound to where they can identify if there are any masses present. So health promotion for men. Screening should be done annually after 50 years old. And again, it would include your digital rectal exam. And then it's questionable right now if they're saying that a PSA should be done. It's not routinely done, but it is recommended after 50 years old. So that is something you do want to encourage your clients to have done after the age of 50. They also need to do a monthly testicular exam from puberty to about age 40. And you can teach your clients, the best time to do this is after a warm shower or bath in front of the mirror. And then both hands will cup the testes and examine for swelling, pain, or lumps. And there's a picture there kind of an example on how you would do a testicular self-exam. And if there is any changes, contact the doctor for a more thorough exam. You can also let your clients know that it is normal for one testicle to be larger than another, so that is not something that should be of concern. Diet, you want, as far as health promotion, and have them increase, have high fish, omega-3s, have a lot of fruits and vegetables. A high calcium will increase the risk of prostate, so the calcium they do need, it's not like you have to really, if they're doing everything in moderation, it's fine, but an increase in calcium causes an increased risk of prostate. And then lifestyle, you want to decrease alcohol intake, which can cause, affect the liver, and smoking, which can cause lung cancer or bladder cancer, like you had just learned. Self-neglect, could cause a lack of health promotion for men, and then failure to use services. So make sure they know what services they have available to them and what they can do for routine health care. So age-related changes for men, when there is a decrease in testosterone as they get older, there is a decrease in your muscle mass, an increase in fat that accumulates in the abdomen. There may be a decrease in energy, but an increase in irritability, a decrease in short-term memory, and a decreased sex drive. They may have an increased prostate enlargement due to increase in estrogen, but they will have a decreased sperm count. So again, these are normal changes as a man does age. Okay, so some prostate disorders that we're going to go over includes benign hyperplasia, or it is also referred to as benign prostatic hyperplasia, or BPH. This is an enlargement of the glandular tissue due to endocrine changes associated with aging. It occurs in the innermost aspect of the prostate. So if you look at the picture to the right, you will see an example of a normal prostate and then an enlarged prostate. And then they could also be at a risk for a prostate cancer. This is an androgen-dependent adenocarcinoma. This affects the outer section of the prostate, and it is slow growing. The survival rate is very good if diagnosed early. Prostate cancer will spread by direct extension. It'll go into the lymph nodes and the bloodstream if not caught early enough. It can also metastasize to the bones, primarily the pelvis and the spine. So if you look at the picture on the bottom, there is a picture of a tumor with a prostate with the different stages of the tumor, and you see it does affect the outer section. Okay, so incidence in BPH, 50% of men over the age of 50 will have this, and 95% of men over the age of 70 will have some sort of BPH. Prostate cancer is the most common cancer in men, and as the population ages, we will see more prostate cancer. Risk factors include family history, a diet high in animal fat like red meat, and then the African American male is at an increased risk for prostate cancer. Clinical manifestations for BPH include urinary obstruction symptoms, so they may have retention or urinary stasis. Gradual onset of symptoms, so they may have urgency, nocturia, or hematuria. And the location of the enlargement affects symptoms more than size of the enlargement. In prostate cancer, early stages are usually asymptomatic, and then they will develop symptoms of BPH. In prostate cancer, hematuria is a late symptom. When it metastasizes, the pain will radiate from the lumbosacral area to the hips and legs, and you will have a client complaining of bone pain, and it will have weight loss. A high testosterone is dangerous, but a decreased testosterone may indicate worsening of low-risk prostate cancer, which is an aggressive prostate cancer. Complications include urinary tract infections. They may have pyelonephritis or renal failure. So if you suspect someone with a UTI, check a CBC and a UA on them. And for renal failure, again, your BUN and creatinine are the labs that you're going to look at specifically. Other complications include obstructive disorders like hydronephrosis. And then collaborative care is to restore bladder drainage, relieve the symptoms, and prevent or treat any complications that occur. So for BPH, if there are no or they're just mild symptoms, there's just watchful waiting. We're just going to keep an eye on it, and make sure that it doesn't get worse. But the treatment usually is not much at this point. They may do non-surgical invasive care, so they may perform intermittent catheterizations. A stent may be placed to hold back the walls of the prostate, or they may do dilation, which is not a permanent solution, but it is useful for surgical risk patients. So if you look in this picture to the right, you can see that they put a stent in the urethra to kind of hold back the prostate so that you could get urinary flow. Pharmacological focuses on shrinking the prostate for BPH. There is something called 5-alpha reductase inhibitor, or 5-ARI. And this is the med that you'll hear for this is Proscar, and it takes about 6 months to work. And erectile dysfunction is a side effect. So, education again is very important, but I have seen us give many elderly men Proscar for their BPH. To facilitate urinary flow by relaxing smooth muscle relaxation for BPH includes giving an alpha adrenergic receptor blockers or an alpha blockers like Flomax. So, that is something that you may see given for urinary flow. And then focusing on reducing androgens to slow cell growth for like prostate cancer. They may give a luteinizing hormone releasing hormone like Lupron. And that's up on the slide also. And this ultimately will reduce testosterone. And some side effects you may see are hot flashes and flushing with Lupron. So again, it is important if they are on a luteinizing hormone releasing hormone medication, that they do know the side effects of hot flashes and flushing, but this will focus on reducing androgens to slow the cell growth, which would be a risk for the prostate cancer. And then some patients may, be on the internet trying to figure out what to do here, and they may be taking an herb called saw palmetto. This doesn't decrease the symptoms of BPH, but you may hear that they are on it. So as with any type of herbal supplement, make sure that your doctor does know that in the med rec, so he can let this person know if it may be going against some other medication he's on. So surgical therapy is indicated when there is persistent residual urine, there is acute urinary retention, if they have hydronephrosis, or if they have prostate cancer. Surgical therapy is the first line of treatment, and it is stage dependent on how far along the prostate cancer is. So they may do a resection of the prostate. It's called a TURP. So it's transurethral resection of the prostate. And they take a resectoscope into the urethra to excise and cauterize the prostate tissue. And then they will put a 3-way Foley inserted with continuous irrigation. This will provide hemostasis in urinary drainage, and it prevents obstruction from blood clots. So advantages of a TURP is there are no external incisions, there's less risk of erectile dysfunction, and there is less risk of long-term incontinence. The disadvantage is that it does not completely remove prostate tissue, so there is a potential for reoccurrence. There's a false security that their cancer has been cured. So again, education is very important when discussing these types of options. There is also a suprapubic resection where a large mass of tissue greater than like 60 grams will obstruct. This is a large prostate. It could be benign or cancerous. There is an abdominal incision that is made that removes the gland completely. The urethra is sutured to the bladder, and then a suprapubic catheter is placed. There's a 3-way Foley in the urethra with irrigation. This is a longer recovery, and this is difficult to do in obese patients. And then we've got our laparoscopic prostatectomy, where there is 5 incisions, and if you look, there is a picture of one that is done here. This is a difficult location, but becoming more popular due to the shorter hospital stays and decreased nerve damage. And then we're going to be going over the radical prostatectomy on the next slide. So you can see here with a radical prostatectomy, whenever there's a radical procedure, we're taking out more, right? So they're removing the entire prostate, the lymph nodes around it, and the seminal vesicles. So it is a large area of resection. Once that's done, there is a catheter is placed that will drain the urine from the bladder. Palliative care for prostate cancer is done when metastasis has already occurred. They may do a bilateral orchiectomy, which is a removal of the testes, which will decrease their testosterone source. It does relieve the obstruction, so the symptoms may be relieved, but the client will be put on hospice. They may do radiation therapy internally or externally for the prostate cancer. So with post-op care, hemorrhage is always a big risk. Blood clots are normal for the first 24 to 36 hours. Bright red blood indicates excessive bleeding. To decrease the bleeding, your client will be on continuous bladder irrigation, or CBI. You won't want to run the irrigation fast enough to keep the flow pink or clear. But your clients are at a risk for hyponatremia, fluid overload, and water intoxication. So you want to watch those sodium levels. The sodium may drop due to large volume bladder irrigation, so you may slow down the irrigation if the urine is pink. Okay, so this takes time, and it's a very time-consuming thing when you have somebody on continuous bladder irrigation, because you want the fluids to irrigate fast enough so you don't develop more clots, but you don't want to do it too much that you could cause some of these other side effects. So by slowing down the irrigation, you have less risk for fluid overload and sodium dilution. You may have to do hand irrigation for blood clots. So if you look at the picture, pretty much, I don't know why there's a bulb on the end of it, but I grab one of those Toomey syringes, you know, the syringes we use for like the G-tube feedings, and I will take normal saline or sterile water, depending on what the surgeon head wants, and you will actually try to irrigate. You'll attach that syringe tip to the one of the ends of the catheters, and you'll try to irrigate it. And let me tell you, you need to make sure that you hold on to that syringe because you may be pushing kind of hard and kind of moving the syringe back and forth to get the water in. And if that slips, that will spray everywhere and you may have a bloody mess. So just, you guys, please, if you do this, take caution. I'd put a gown on. You may even want to put a face mask on, honestly, because if it slips and you're trying to push fluid through because there's a clot, sometimes it takes a lot of force to do this. You may need to put traction to apply pressure to the bleeding site, but prolonged traction will result in tissue necrosis locally. So that's something, I haven't seen someone put in traction myself, but that is something that may be done with post-op care. You want to avoid prolonged sitting or walking, so we need to kind of do both, and avoid straining for bowel movements. So high fiber diets and stool softeners are a must with these types of procedures. If your client has a bladder spasm, it's a result of bladder irritation from either like the uroscope, blood clots, or a catheter. You want to check for blood clots, and you want to administer antispasmodics. There's something called B&O, which is belladonna and opium suppository, and those are a narcotic. So obviously you'll have a doctor's order to give this type of suppository, or they may be giving ditropan for bladder spasms. They may also have urinary incontinence or erectile dysfunction with these types of treatments. Okay, moving on, testicular cancer. The incidence is on very young white males. Ages 15 to 34 years old is the average. And again, it is white males that are at predominant risk for this. Predisposing factors include a history of mumps, an inguinal hernia in childhood, or an undescended testes. Clinical manifestations could be a scrotal lump. The lumps are painless, non-tender, and firm. There may be scrotal swelling. There may be no sperm count or a decreased sperm count related to the increase in temperature from the cancer. And then metastasis may be symptoms from other systems, like a lower abdominal ache, testicular pain, or an enlarged lymph nodes. And on this slide, if you look, there is a picture of someone with testicular cancer and then how a normal testes should look. So, collaborative care in this, they may do a radical orchiectomy. Here we go again with that radical name. So it's radical orchiectomy. It's a removal of the testes, the spermatic cord, and regional lymph nodes. Tumor staging of the tissue and lymph nodes is done, and they may do an implantation of a silicone prosthesis. So for nursing interventions, you need to provide scrotal support, so you want to make sure, that they're comfortable, and they may have like a pillow under them, and no lifting or climbing stairs after they have this done, until they're healed. They may do chemotherapy or radiation in conjunction with the surgery. External radiation would be radiation of the lymph nodes, and then you want to shield the viable testes because there is a decrease in sperm count related to radiation, but that is temporary. So prognosis has been improved. There is a 75% cure rate with early detection, and that's why these clients must have regular follow-up. And they may actually, you may want to recommend a sperm banking because sperm collection should be done before radiation or chemo or a radical lymph node dissection if the client is younger and may want children someday, because it's not guaranteed that their sperm count will increase to where they could have a child. So if you go and get that sperm banking done before the procedure from their healthy sperm or testes, then they have that option to have children in the future. They are at an increased risk for secondary cancers, and there is a possibility of problems with erections and fertility. And again, that's going back to the sperm banking. And again, as always, provide emotional support throughout any types of these procedures and diagnoses. Okay, moving on to erectile dysfunction. The incidence, there's over 20 million men in the U.S. that do suffer from erectile dysfunction. Most men will wait 2 years before seeking medical assistance, and it's most commonly in the ages of 55 to 65 years old. This is the inability to attain or maintain an erect penis for a satisfactory sexual performance. And there's different causes, organic versus functional. So organic is gradual due to either injuries, some sort of vascular problem, endocrine, smoking can cause erectile dysfunction, some medications can cause this, and then some of the surgeries they may have. And in functional, it may be more psychological or stress related. So complications, a big one, is distress in interpersonal relationships and masculine image. This is hard for a man to go through, especially if they hadn't had problems and now they're 55 years old and suddenly they are having erectile dysfunction. So collaborative care, you want to involve both partners and give realistic expectations. And again, collaborative care is based on the cause. If it's physical, like if they have a chronic medical condition that it could cause this, like diabetes or hypertension or recent prostatectomy, it's more managing the disease process or the surgical care afterward, that can help possibly reverse some of this. Or it could be medications, your SSRIs. There is a increased risk of erectile dysfunction with those. Alcohol consumption. If you have a lot of alcohol consumption, you could have erectile dysfunction. So these are things that you want to educate your clients on. And if it is psychological, you do want to refer them to a qualified therapist, to help them discuss this and, come to some sort of treatment to where they can hopefully have less psychological stress, so that they will not have the erectile dysfunction. But again, that's not something as a nurse that we are trained and qualified to do, so you do want to refer them on to a qualified therapist. So for erectile dysfunction, drug therapy, there could be an androgen replacement therapy. There is also a vasoactive drug therapy. There is something called phosphodiesterase inhibitor, which is PDE5, which increases blood flow to the penis. Some of the meds, and I'm sure you guys have heard these, are Viagra or sildenafil, tadalafil or Cialis, or vardenafil, which is Levitra. And this potentiates hypotensive effects of nitrates. And they also need to avoid alcohol also. So what does that mean? That means if a male has taken a drug like Viagra in the last 24 hours and they have chest pain and you want to give them nitroglycerin, you should not do that because it will potentiate hypotension. You could bottom their pressure out if they have taken one of these PDE5 medications in the last 24 hours, and then you give them nitroglycerin. So we actually educated our paramedics that when they respond to somebody that has chest pain, they do ask the males if they have taken something like Viagra in the last 24 hours. So that way they will know whether to hold or to give the nitrates. The statins can increase erectile dysfunction. This is due to vasodilation of the penile arterial system from increased nitric oxide. So they may prescribe a statin. And a medication failure sometimes happen because there's an incorrect use of meds 50% of the time, because there's an increased dosage or not taking long enough. So again, it is important to teach proper medication administration and for them to stay on it. Sometimes these things will not work right away. Surgical, they may do penile prosthesis. So, you know, I have a slide on this here to where there are different types, but they will actually put in an inflatable prosthesis on some of your patients with erectile dysfunction. And they can ejaculate if they do have one of these in place. So nursing management, you know, emotional support. You have to give emotional support for somebody that is experiencing this, you know, and is having a problem with it, because that is, you know, very big deal, you know, for a man that has erectile dysfunction. You do want to provide confidentiality, you know, so this isn't something you're going to go and be like, oh yeah, Mr. So-and-so has this, you know, because again, would you want someone to know, you know, if you were experiencing any of your health problems? So again, provide confidentiality and give them accurate information, okay? Because giving them inflated expectations or results is not healthy, you know, so again, be accurate with the information you provide. All right, that's it. Oh my goodness, I've talked way too long. But if you guys have any questions, please let me know. We will be going over some of this in class. And yeah, here we go, guys. This is week 15. I'll see you soon. Bye.